So this is the first of our two panel sessions where we're going to look at both cancer prevention and then we're going to look at opportunities afterwards. So we're going to present two cases. My colleagues from the Academic General Practice Group, John Hall and Kerry Bell, each have a case for you, and then we have an excellent panel who are going to review what are the issues from their perspective about these cases. So I might actually ask them to come up and I'll just briefly introduce them. So John Hall's just coming up to present the case, but while we're doing, and Kerry Bell, but while we're doing that, Jennifer Olding, nutritionist, Brianna Clifford, exercise physiologist, Professor Jerry Greenfield, endocrinologist, Professor Freddie Sitas, who's been introduced to you already, and Associate Professor Amani Zekri, hepatologist. So there will be opportunities for interaction as well, but because we've got some small group learning, this is more about getting some additional thoughts from those involved in intervention. So we better get moving. Liver cancer.
Yeah, my name's John Hall and I'm from the School of Public Health and Community Medicine, and so at UNSW. Now, this is on hepatocellular cancer of the liver, but in fact, it's got my name there, but the case was actually prepared by Amani Zekri, who is sitting out the front here. So, so that's the wrong name there, because this is very much Amari's, and I think an actual patient of Amari's. So the case we're talking about is Miss LR, who's a 59-year-old. She's a professional nurse. She's had obesity since her late 20s. Her BMI was 30 and has increased slowly over the last 12 years to 36. She was diagnosed with type 2 diabetes 8 years ago. She's on metformin 1 gram twice a day, and her latest HbA1c is 7.2, so she's got reasonable control. She has been diagnosed with hypercholesterolemia almost 8 years ago. She's on atorvastatin 10 milligrams daily, latest cholesterol 6.2, HDL of 1.0. And her blood pressure is currently borderline at 135 on 85 with a large cuff. She's a non-smoker, non-drinker. Her exercise, she walks to and from the bus stop and at work, and she's presented to you as her GP for a checkup. She's going on holidays, and she's complaining of tiredness and right upper abdominal pain for some months. So when we do a routine blood test, this is what we find. And so the results that aren't within the reference range are that her albumin is low, just below the reference range. Her transaminases are raised, and the other notable thing is that her platelets are decreased. So the questions are, so Amani, do you want to talk at this point? Okay, so what when we get this back, what are we thinking of? Fatty liver? So Amani, so what are we? The transaminases are up, the albumin's down, and the platelets are also down. Fatty liver? Sorry? Cirrhosis? Why? Sorry? Okay. One of the possibilities. So fatty liver, cirrhosis. Now, maybe at this point, hepatitis? Would we see the changes?
Thank you. So regardless of the cause of the high liver enzymes, the key things to note here, and if there's anything I would like to send a message as a hepatologist, is to look at the albumin and the platelets. Because Being low, that means we're dealing with advanced liver disease with portal hypertension. So we have actually crossed the line. We've gone into danger zone now. So this lady has had, when we actually looked at her liver enzymes for the last few years, we found that her albumin was declining over the last few years, and her platelets were declining. Her blood pressure was being checked, her diabetes was being checked, her cholesterol was being checked, but no attention was paid to the abnormal liver enzymes. And that's where the role of the general practitioner is so crucial, so important. So this lady basically has advanced liver disease with portal hypertension based on the declining albumin and the platelets. In this setting, the AST and the ALT, it doesn't matter. They can be normal because they can run out of liver cells to give you ALT. But if you find the low albumin and the platelet, then we have switched to danger zone. Fatty liver is a component of a spectrum of disease called non-alcoholic fatty liver disease. So if just steatosis, that's not a problem. But steatosis go to steatohepatitis, which is inflammation and fat, and then to cirrhosis, and then to liver cancer. So she's been traveling throughout this journey without somebody saying, look, you're actually traveling through a very dangerous journey. We need to put a stop to it. So, and basically when she presented at this stage, this is now liver cirrhosis with portal hypertension, probably due to the metabolic syndrome, and that's non-alcoholic fatty liver disease. So fatty liver alone is not a diagnosis, it's a spectrum, it's the early spectrum of the NAFLD sort of spectrum, okay? So a key message, albumin and platelets.
Albumin and platelets. So then in March 2017, she has an abdominal ultrasound, and this shows a MASH lesion in segment 8 of the liver, and the liver appears cirrhotic. So has serology, ANA negative, Hep C negative, Hep B negative. In April 2017, has a CT scan of the abdomen, which shows hepatocellular carcinoma, and has an alpha-fetoprotein of 100. And she's treated with TACE. Now, Amani, can you tell us what's TACE and how this fits?
So can I just maybe, because I want to get as many messages as possible out of this case.
Yes.
So one of the things, because somebody mentioned imaging, ultrasound is not a good diagnosis of liver cirrhosis. So ultrasound will only pick liver cirrhosis in advanced cases. So we need just to make this point clear, because we also get late referrals because the ultrasound was normal. So or the ultrasound showed fatty liver. The other thing, if there's fat and cirrhosis, or some ultrasonographers can sort of mistake fat for cirrhosis and vice versa. So ultrasound is not a very reliable marker. In this lady, I don't need to do a fibrous scan or do anything to know she's cirrhotic, because her biochemistry tells me that she's cirrhotic. But in earlier cases of liver disease, or if they're starting to cross the boundaries, on your iPhone, there is an application for calculating EGFR and so forth. In it, there is something called NAFLD scoring, which you put your diabetes, your patient weight, your ALT, and it gives you a score which can predict whether the patient is fibrotic or not. So that's something which is non-invasive, which can be used in general practice to determine whether the patient has liver disease or advanced liver disease and need referral or not. Because early intervention in this lady could have stopped, could have prevented liver cancer, no doubt. So that's one point. So TACE basically trans-arterial chemoembolization. Liver cancer, as you know, does not pick up systemic chemotherapy. So we actually have to give the chemotherapy or embolize straight into the cancer itself. So it's a procedure which is done like an angiogram, but we get from there to the liver cancer and give the chemotherapy straight into it. It can be done by just getting from the groin or from the radial artery, like we do an angiogram, just to get to the cancer and give it chemotherapy. It's not for everyone. These sort of decisions are made in multidisciplinary meetings. So obviously she wasn't a good surgical candidate at that time for variable reasons, because it was early cancer and we've detected earlier, would have sent her to surgery. So TACE was probably to try and see how she would respond in that setting.
Questions? So what were the risk factors for hepatocellular carcinoma here that that should have been picked up on? Obesity, okay. Yeah. Amani, go on, over to you.
Yeah, so it's a clinical risk factor. So obesity and what else?
Probably our genetics.
Sure, we will one day we'll find the answer to this. Yes, microbiome maybe. So in it, not only obesity, because thank God not every obese person has liver cancer, but obesity is a risk factor. But in it also she had metabolic risk factors. So she's diabetic, and that's why we're seeing actually liver cancer in diabetic lean people. So there is an epidemic of liver cancer now, and that's why I'm so keen that everyone gets a message out of this. So she's diabetic, she's hypercholesterolemic, she's got central adiposity, she's got hypertension. So she's really a good example for the metabolic syndrome. So all these are risk factors for hepatocellular carcinoma, and they don't have to exist together. But diabetes is a very high risk factor. Did you want to make a comment about it?
I think you make a very good comment, and it's interesting that you're seeing now hepatocellular carcinoma in lean people, and that really highlights, I think, the importance of the metabolic syndrome and central obesity. There are many overweight and obese patients out there who never develop diabetes, and they don't have the metabolic syndrome, and they're not insulin resistant. Lean patients can have insulin resistance and metabolic syndrome and central obesity, and obviously overweight patients as well. And I think it highlights the importance of underlying insulin resistance and the metabolic syndrome in driving these cancers, not just obesity on its own. And Kyle showed some nice data that might actually support that as well. So the best thing you can do is really measure the waist circumference, irrespective of the weight of your patients, and that should be the number one key risk factor, not obesity itself. In theory, you can measure insulin resistance in general practice. I never order an insulin level in any patient. I think a waist circumference is a cheaper and more efficient and quicker way of actually documenting the presence of central obesity and metabolic syndrome than an insulin level in any patient.
Would the control of her weight made any difference here? And at what point? That's to the audience.
Yes, but much earlier on, not at the time that she already developed metabolic problems. So I guess we need to address these things earlier on.
She's had diabetes for 8 years. I think sometimes we do tend to get a bit pessimistic about treating our obese patients. She needed to have much more active involvement early.
A change of diet.
Also, does this patient have a significant sign of a social problem? She's a nurse, and she will have increased overweight in her early 20s. And I found a lot of my patients have some anxiety, depression, and long retention problem. They can't control the weight because they can't eat. And depending on what kind of intervention they have. So they go that stage. Her weight and diet should not really control. And as a nurse, I'm sure she knows all these risk factors, her colleagues and her, And I don't know why she's still got a stage and steadily increased her weight for the last 30 years. And also another thing is they did not do this patient alpha protein fit early. If you have a liver abnormality, I normally do alpha protein yearly for that kind of patient.
Yeah.
I don't know when they start doing alpha protein.
I'll comment on that, but maybe you comment on that.
Yeah, I think they're all very good points. There are many drivers of obesity. There are obviously genetic factors which are underappreciated, dietary and lifestyle factors, psychosocial factors, and all of these are important. This nurse might also work shift work, have a poor sleep pattern. All of these things have probably contributed to her excess weight, and some of my colleagues may want to comment on that. But we have so many drugs now that are available to treat type 2 diabetes which don't promote weight gain, in fact, a weight loss medication. So the GLP-1 receptor agonist would be perfect for this patient, would have been perfect prior to her developing her HCC. It reduces appetite, and we can talk in the smaller groups about how these drugs work, but they lead to an average of 5 to 7 kilograms weight loss, and that would have made a huge difference, as we heard earlier, in terms of her risk of cancer. We have the SGLT2 inhibitors, which also promote weight loss and have cardiovascular benefits. So we have a lot of tools now that we can use. I would argue that her HbA1c should be less than 7%, and that she's got inadequate glycemic control. You can push the metformin dose, and we heard about the benefits of metformin in prevention of cancer even. And we know the patients who take metformin who have type 2 diabetes have a lower risk of developing cancers than those who have type 2 diabetes and don't take metformin. The jury's still out about whether or not it should be included in cancer regimens or for reducing the risk of recurrence or progression of tumours. And there are a lot of studies that are currently going on in prostate and breast cancer and bowel. But I think the key thing, I agree with all the messages, 10 years ago this patient should have had her obesity addressed. Having said that, it's not easy. And it's not easy to make patients lose weight or to help them lose weight, otherwise they will do it on their own.
Can I just jump in there? What about, it's kind of a nihilistic message in a way. She's already got it, didn't recognise it when we should have. Big message for the next 10 years of patients I'm going to see. But is there any value, even at this late stage, in focusing on her weight and weight loss? So I'm maybe busting to say something on it, but then I might want to hear from Jennifer.
Yeah.
Jennifer, do you want to say something?
Sure. The question is, would she benefit from weight loss now that she has liver cancer?
The complexity of trying to do it in someone who's already got a cancer as opposed to at an earlier stage.
Sure.
And then since you have the microphone, had you got access to her 5 years earlier, what strategies you would have done together with your GP colleague?
Well, as we've heard this morning, achieving weight loss is a difficult thing to do, but modifying the diet composition is something that she might benefit from. So, for example, your fruit and vegetable intake alone can improve your risk of developing cancer, particularly colon, and there's other evidence in some GI cancer sources and breast. So for her, it's not so much eat less and lose weight, but eat more of the good stuff and reduce your risk of cancer recurrence. And eating a better quality diet during cancer treatment can improve outcomes. So, for example, taking enough protein and reducing your chances of loss of skeletal muscle mass can reduce complications from cancer treatment. Reduce length of stay, and for example with colon cancer that is resected, you have a reduced risk of operative complications and length of stay when you've got enough protein intake in hospital.
And if you had been in touch with this patient 5 years ago, any different?
It would be in addressing her cholesterol and glycemic control first and foremost. Because of the benefit of dietary intake on weight loss is minimal. It needs to be multidisciplinary through medicine or surgery, exercise as well as diet, but you can improve insulin sensitivity and cholesterol through diet alone.
Yep. And how about exercise physiology?
So I guess in the same thread, maintaining lean muscle mass is really important. So exercise can contribute to weight loss, but one of the, the main benefits of exercise or remaining active is that you build up that lean muscle mass, which is metabolically active. And so I guess we heard a little bit about that teachable moment that sometimes occurs with a cancer diagnosis before, but it almost seems like, unfortunately, there could have been an earlier teachable moment where maybe lifestyle modification might have been a more appropriate or more effective at that time. So certainly 5 years ago.
So she's already walking to the bus stop and does a lot of walking at work. What else can we offer her?
So I guess that incidental activity is one portion of physical activity levels, and it's very important that people are able to accrue physical activity by doing things in their day-to-day life. Particularly when people have metabolic disease, we know that resistance-based exercise, so exercise that builds up muscle mass, is really important. So outside of walking to and from work and walking or being active at work, having 2 resistance sessions per week that are actually aimed at building up that muscle mass is the most effective form of exercise for this type of patient.
Can I ask you both, when I do a GP management plan, I've got five sessions under Medicare. Who do I send them to? The dietitian, the exercise physiologist?
Me.
Where do we get the best bang for the...
So in addition to the enhanced primary care scheme where there's 5 sessions, there's other Medicare covered services like the Get Healthy Information and Coaching Service. So this is 10 sessions with a health coach. That health coach might be an exercise physiologist, a dietitian or a doctor, but what they're doing is help to coordinate care and empower the individual to make healthy changes. That might mean using their 5 sessions to focus one-on-one with the expertise of a dietitian or an ex-phys, or it might mean teaching them accountability and self-management skills. And those 10 sessions occur over the course of the year, and then it's renewed year after and year after. So if we're imagining a teaching moment for this lady, maybe when her BMI was first measured at her GP consult 20 years ago, enrolling her in the Get Healthy information and coaching service, another moment when she gets her diabetes diagnosis, again you're enrolled, and so on and so forth. And Get Healthy has specific arms for pregnancy, for Aboriginal, for diabetes, for young people and for alcohol users. So it's quite a tailored approach to lifestyle modification.
And what's the evidence for that? Does it make any difference?
The health coaching model,
Yeah.
what's the evidence base behind health coaching?
Yeah, is it, but yes.
Yeah, it's interesting because nutrition is not so much a medical science but a behavioural science. We saw before about feeding rats fat or sugar, but humans have that behavioural component. So a health change coaching model is the most effective way to modify eating behaviours.
And the same with exercise physiology?
Yeah, absolutely. It certainly doesn't work alone. It needs to be multidisciplinary. But just adding to that, particularly depending on what kind of, obviously there's the 5 allied health sessions that they have available to them, but with a diabetes diagnosis, there's group training that's available. On top of that, with a cancer diagnosis, there's a number of different, services that are available that can be sought out through the Cancer Council that are both distance delivered and free, or face-to-face like the Enrich program. So outside of those very specific one-on-one clinician-facing sort of sessions, which I think are important, particularly if people need a lot of support, there are other options for people to reach out to and get support in different forms.
Yep. Jerry?
Just one quick point. I think everything that's been said is actually so true. We're failing as a medical profession really in helping people to lose weight, and you can't do it on your own. A multidisciplinary approach is the key to do this, and people need support. They need to see a life coach, a dietitian, exercise physiologist, physician, bariatric surgery, all in the same place, I think at least, and have that support. And the program needs to be months, not weeks or days. And it's a really difficult thing to do, and people need to be supported. And I really think that a multidisciplinary approach is really the way to go. And there are very few clinics or processes out there that really encompass all of those things. And it's the key.
Great. Thanks, Jerry. Freddie?
I think we should write a little manual on how doctors can be incentivised to introduce prevention programs to patients. One of the things I've started getting involved in how do GPs get involved in more prevention recently, but what strikes me is that, patients come in for a condition and they don't like being told about other conditions. And that's a big barrier perceived as a big barrier to changing the conversation. You come in with a stubbed toe, all of a sudden the doctor's talking about something else. And so that's a conversation piece that is a difficult one. And we need tools and devices to, things like we use cholesterols or, mechanisms to change the topic into something that's more preventive. So there's room for, I guess that's why you're here on this course, but I think there's room for increasing the clinical indicators to start a conversation around prevention, around BMI, smoking, and all the other good things here.
Okay, thank you very much. So I'll hand over to Kerry Yubel. Oh, sorry, yes.
Just a couple of comments. Firstly, we don't get reimbursed for chronic complex patients if they've just got obesity. They have to wait till they get sick.
Yes.
And secondly, I think the Get Healthy program is available for everybody. It doesn't have to be a chronic complex health patient.
And it's all over the phone. So you don't need to attend an appointment or,
Yes.
They can?
They can, yes.
You just phone up the number. I've got brochures.
Next one.
Okay, just another technical difficulty, but most of the panel discussion part is going to apply equally, but Amani wants a minute while we're fixing the slide.
Yes, I use my curse to do this. And there was an important question from the audience about what you could have done with screening for this patient, which is really another learning point, which if a patient have advanced liver disease like cirrhosis, if we've detected cirrhosis earlier, number one, she could have been on a screening program for hepatocellular carcinoma by 6 monthly ultrasound, so that's twice a year. and AFP, and that would have detected the tumor early enough to operate on. So that's the prevention. Number two, we could have intervened early by all the strategies we spoke about to start to try. And yes, even if she's at that advanced disease stage you were asking, yes, there is a premise for intervention at that stage, because people who have all these risk factors and obese actually respond worse to TACE and all to the cancer therapy compared to people who are lean and have less metabolic risk factors.